national CMS-sponsored project, Transforming Clinical Practice Initiative. There are 20-some organizations like VCSQI who have contracts to recruit practices and help move them towards a value-based way of business. Last June, at a meeting in Baltimore, CMS told all of us, go to your practices, go to your prescribers, and help them revisit what they're doing with opioids. Made it a priority. And that's part of what we've been talking to the original VCSQI members as well as practices enrolled in our project. The survey that Eddie mentioned, we're going to send out again very soon to everyone. 3 of the questions on that are things you both mentioned. Are you doing a risk assessment? Do you have a signed treatment agreement with the patient? And are you doing follow-up monitoring? Okay. Those also are 3 measures now in the CMS list of quality measures for MIPS.
Perfect. That's awesome.
It is. It's doing the right thing, although there's some criticism about those as quality measures because they're not evidence-based at this point. They're not clearly defined. You know, they're easily gamed. Have you heard anything along those lines or any research that's showing that a signed treatment agreement makes a difference?
Yeah, I mean, we hear that every day, but it forces the patient to do what's medically right for them, to some extent at least. I mean, it's the power of the pen. How else are we going to regulate this? How else are we going to get a handle on this? We have to do something, and I mean, I don't like everything about the regulations, and they force me to do a whole lot more paperwork when I do write for prescription drugs. But holy cow, I'm in favor of it because I think it's going to make a difference in the long run. So I just think it's what we have to do.
One of the questions we're getting from some of the practices is, so you get a signed treatment agreement with the patient, and some say don't call it a contract, call it a treatment agreement.
Yeah, there are legal things like that.
But
we call
what do you do with the patient who doesn't follow it?
Discharge them.
Send them off.
Yeah.
Discharge them.
It sounds like a question I commonly get is a follow-up with that. Well, what is my patient to do now because nobody else will take over that function? But again, nobody's going to, generally speaking, die from opioid withdrawal. Okay, it's rarely that critical of an event. Even if they've been on for years. It's not a life-threatening withdrawal problem. So I think we just have to, we've got a problem in the nation, we've got to tackle it somehow. Regulations are the start. Even if you go back to the old opium wars, you know, that was solved by restricting supply. If you go back throughout history, 2,000 or more years, it was always addressed first by restricting supply. So it has to start there. And the opioid agreement is just, it's a doctor-patient or a provider-patient relationship. It's a seal of we understand each other and we're going to work together on this. And I think that's the only good way to do it. I hope that answers the question.
It does, it does. How much attention do you put into teaching patients and family members how to discard their unused opioid medication?
Okay, that's a good question. Why don't you answer it? I've been
It's actually critical because when you're looking at that 11, from my point of view as a pediatrician, not a cardiac surgeon, when you're looking at that 11% of high school kids that are taking the drug, it's because it's in the house. It needs to be disposed of, and that is part of the veterinarians. I just sat in on their regulatory advisory panel today. And they put it in their regs that they have to they can't counsel their patients about the risks of opioids because their patients bark, but they do counsel the families. And the important thing to know is you can't flush it down the john, because if you flush it down the john, it's potentially in the water supply. So, and it's out, you know, if you have a septic system, it's out in the grass. So it needs to go back to, you know, get it back to the pharmacy, get it back to the doctor, get it back. Don't flush it down the john.
Absolutely. Yeah, that should be discussed every time. I read something, I'm originally from Michigan, so I read something the other day that Prozac and other antidepressants are showing up in increased supplies in Lake Michigan salmon now. I mean, all this stuff is getting into our water supply, so we need to cut that short. I like salmon, personally.
Yeah, I do too. You had a question, Hal.
I'll raise a little bit of objection, and it's not a big, with a big O, but a little O. And just in terms of, when we're looking at the pain management after open heart surgery, you're looking at an average length of stay between 4.8 and 5 days. And the discussions overwhelmingly are anxiety producing is related to mortality and morbidity. Mm-hmm. And to tag onto there, now we're going to end up and say, we want you to sign this contract because we're going to start talking to you about pain management. Maybe I misunderstood what you were saying, Deb, but at the same time, that's the least of my problems. And I think I can speak for most of us here. And we get caught because it's often, and I appreciate about the assessment because I really haven't thought of it in that context to anticipate the providers and with whom we're dealing. But these discussions are overwhelming, and the least of our issues are pain management in the pre-op setting, at least from my perspective.
You don't
might disagree, but
you don't need to do that in the acute setting,
acute
ever.
setting. Ever, yeah.
Ever.
Ever.
Don't even concern yourself.
Maybe I misunderstood how
We're talking about chronic pain mostly, okay? So in that case, you can prescribe 7 days of a drug, for that surgical episode. If they come back to their first post-op visit and they see your PA and they're still having pain, then she can document, so-and-so had a complicated sternotomy that, we had to go back in, or whatever the cause is. Document what the problem is and why they want to rewrite for additional medications. And that if that persists beyond, some reasonable period, a month or 6 weeks or whatever, then I think it's time. This is turning into a chronic problem now. Joanne, we need to discuss, next steps, and I think we need to have you sign this agreement now.
Thank you. I just want to clarify that because it wasn't.
Right, it's not, there's a difference between chronic and acute pain.
One of the things that we're doing, we've reached out to STS to offer to work together, Society of Thoracic Surgeons.
Yeah, thank you.
And have met with them at their annual meeting in January with some of their evidence-based developing staff, evidence-based guideline staff. So we will be forming a work group, and some of you in the room have volunteered to potentially serve on that work group that will hopefully yield a position paper. Because there is not enough evidence to support true guidelines with cardiothoracic surgery patients.
Yeah.
So hopefully a year from now, I don't know how long this takes, Dr. Spear, but the society will come out with a position paper, perhaps two, whether cardiac surgery can be the same as thoracic surgery, we don't know yet. So that's, I think, an exciting endeavor that VCSQI helped launch.
I really think that's the answer, because you folks know your unique problems better than we do, and you're going to have to tailor whatever solutions to those unique populations. And only you can do it, because I learned something from somebody back there about a contraindication I didn't even know about. So.
And thank you for the regulations. We've been sharing them with practices in other states as well to look at and at least consider as they're examining their own prescribing.
Yeah, Virginia is at the forefront of the regulations. We are, believe it or not, we're a model state, model commonwealth for what's being done, mostly because we kept it out of code. They're hard for us in regulations, but regulations are much more nimble than code is.
Any other questions? Stories to share? Anybody doing things actively since our discussions about this began?
Judy, you guys have a new protocol, don't you?
It's not a new protocol, but we were getting, you can only give a week, even though there was the 2 weeks thing up until the thing we just did. But the clinic was getting so many phone calls, over and over again, like they need more payment. So we just put in, there's some language in the, guidelines have changed, and we can only give you a week. If you need to get more pain medicine, you must be seen, either come back to see us, and just setting expectations. I don't think the clinic's got any phone calls since we did that.
And I think that's the thing, to just realize that it's not the regulations that are telling you you can't give more than a week.
Or what's their
But if
insurance
you
company?
need to use the regulations, we are happy to bear the brunt of good medicine.
To be honest, it's a lot of their insurance companies, because if you write, like if you say 1 to 2 or whatever, if you gave them a range, a lot of insurance companies will call the LIPs back and say, you can only give a week, we will not pay for 2 weeks.
So there's one of the things that the regulations left very nebulous. They said 7 days. I mean, are you giving the drug 2 QID, or are you giving the drug 1 TID? And if the Board of Medicine is asked to define that more clearly, they say whatever the label, whatever the package insert says is the usual daily dose. But again, they were meant to enforce good medicine. They were not meant to keep people from practicing well. So that's a huge loophole of that regulation. You know, well, what's a day's worth of medicine? What's a day's worth?
I'm going to ask Ivan to share a story from one of our practices outside of Virginia. The same survey that you all, many of you completed, the practices that we're working with in this project also completed. And that survey prompted something very interesting in this one cardiothoracic surgery practice. Ivan is our transformation improvement advisor.
All right. So last year in November, I think, we sent the survey to our practices. We have a cardiovascular thoracic surgery practice in Orlando, 6 surgeons, I believe, and they are affiliated with an 1,100-bed hospital. So they're busy. What they learned in the survey is that they're all 6 providers are prescribing very differently. There are no standards in the practice. You talk to nursing, different practices for different docs. The president of the group said, well, we should standardize the practice. I thought the same thing. Let's get in there and standardize the practice. We'll get in the room, everybody will, they'll agree, we'll standardize it, and we'll leave. 2 hours, 4 hours, you go home. We thought that, the president and me, so it's not just me. The nurses that sat with us, they taught us a lot. They taught us, one, that you can't standardize what we were trying to standardize for different reasons. The patients are different. What's on the shelf is different. What's happening in the market is different. And so the conclusion that we drew in the room is that maybe we don't standardize, but we have to work with the people across the street in the hospital, in surgery, and the social workers to develop step-down procedures for thoracotomy, sternotomy, is it called, and subcutaneous incisions. And once you do that, we have to develop a plan together for how we're going to talk to the patient up front, how we're going to treat them in the inpatient setting, what we're going to do the first 10 days afterwards, and then how we're going to talk to that patient in terms of their treatment and ongoing care. So a big part of what this practice learned is that they were treating this and looking at this as a group and as a practice. And we have to look at this as a community, as a system, in order to help patients through their inpatient treatment, their outpatient treatment, and with life afterwards. And so that practice just drew the same conclusion. It took about 4 months for us to get to the point from we take the survey to now we have a plan where we're going to work with the hospital and meet, and we're going to work week by week until we get these protocols in place. And that's the journey that that hospital went through. So taking the survey didn't solve the problem, but it led to discovery of the problem and led the hospitals to start to work toward resolving the issues. And that was one success story from that practice that's going to affect That was one hospital. I believe the system in Orlando, that's Florida Hospital, I believe that there's 9 hospitals in Orlando and 19 hospitals within the state. But what we're doing at that, yeah. What we're doing for that one hospital is going to reach the 19 hospitals in that system, and that's a good success for us, I think.
Thanks, Ivan.
Yep.
Any other questions for our guests? Thank you both. Oh, one more?
I got one more. I guess a comment and a question. Dan Woolley from Chippenham. First, a comment to what you said about the fifth vital sign. I think that was the first problem. I think the second problem was that pain is only subjective and not objective.
Right. Absolutely.
Because I have 2 classes of patients, those who tell me their real pain scale and the other ones who always have 40 out of 10.
Yep.
And this is how they have 40 out of 10. I'm dying in pain.
Oh, yeah.
Okay?
My daughter had pancreatitis when she was 17 years old, and she was hospitalized with pancreatitis. I've never had pancreatitis, but I've had a baby, and I've heard people say that it's about the same amount of pain. When you asked Sarah what her pain was, she said it's a 4. She couldn't get up and go to the bathroom. She couldn't move. She was moaning, but it was a 4. She was in a double room. The woman next to her had pyelonephritis and was watching soap operas, and she was a 10.
Right.
So she got, the woman watching soap operas got drugged, and my daughter moaned because it's only a 4. You know, and it's, I'd much rather be the mother of the 4. But it really, you know, she had to be hurt. I mean, she couldn't go to the bathroom by herself. She couldn't get out of bed. She couldn't move to get on the bedpan because she hurt so much.
What that patient is telling you, anybody that's outside the scale, they're telling you, I have depression, I have anxiety, I have other problems that need to be addressed.
Right. And,
Period.
I mean, we're trying to address those with some things now, but sometimes benzos help those people, and they still need a little bit on the opioid side.
I understand. But document.
Yeah. The second question I have for you is, you know, I think back to residency in the 90s. Everybody went home with 100 Percocets. Okay?
Yeah.
And hardly anybody finished them.
Mm-hmm.
And I think they were flushing them down the toilet, which was the wrong choice at that time. But that's what people were being told.
That's what people were
at
told
that
to do,
time.
right.
Or they throw them out.
Yeah.
And we didn't have this problem. Now, heroin wasn't the chief. Cocaine was the chief. Crack was the chief. Meth was the chief. What happened that all of a sudden pills now are the issue? Is it just because there was availability, or has something else changed?
It's a have you read, what's the name of that, Dreamland by Sam Quinones?
I have not.
It was a New York Times bestseller. I would recommend you read that because it goes into everything. I have lived through this. I'm the first pain fellow to ever train in any branch of the military. So I was there, you know, from the get-go. And all these people that pushed the current opioid epidemic, that said that it wasn't harmful and that it wasn't going to cause any problems, they're contemporaries of mine. Thankfully, I never bought into that whole message. But it was multi-societal, the pain societies and other ones. Pain is what we say, what the patient says it is. Patient deserves care. This is what we have. Give it to them. JCO piled on. The industries were only too pleased to make $20 jillion from supplying all those drugs. So it just gets to everything, and that's why it's a problem. And then, you know, maybe life's more stressful now. I don't know. You know, kids started using this stuff at parties. You know, she presented the data. You know, 1 in 10 or 1 in 9 kids are using these drugs now. So it partially is availability, and part of it is just the generalized acceptability of it all, and it just got out of hand. Dreamland, great book, yeah. Sam Quinones. It was required reading at VCU for our new incoming residents this year. It's kind of the book of the year or whatever. But it's a really good book. It's an expose on how we got here, basically.
If I could, I'm sorry, I had one quick thought that just came to mind. The one thing that struck me most from the conversation we had that day is that I walked away and I thought, for us who are involved in policy and stuff like this, we call it the opioid crisis.
Yeah.
And it occurred to me that the nurse whom I spoke to, at no level did she see it that way. I think at one point she turned to me and said, so if a patient calls me in pain, you want me to tell them that we have a policy in place and I can't give them? And at first I thought, you're a nurse, I get that question. But I thought, okay, I get it. She doesn't see the crisis. She hears a patient in pain on the phone.
Right.
And so it's how do we educate throughout the system?
That's why we're here.
Yeah, that was, yeah.
Help me thank Dr. Allison Bryan and Dr. Huntoon for their time this evening.